So my topic is cardiac tamponade, and for me, I put a lot of pictures, and there's really no disclaimer, but I actually need to acknowledge those authors spent time to draw those pictures and X-rays and all that. So I think at the end, when this is just for international purposes because the copyright and all that, we don't want to infringe anybody's copyright. This is just purely for education, and I do not benefit anything from this event. Richard, I'm not getting paid too, so. Yeah, so next slide, please. So for you to understand cardiac tamponade, you need to understand cardiac anatomy. And for you to understand cardiac anatomy, this whole protective measure is also the culprit of the problem. And that's what we call pericardium. Now you can see that this is our lung, and pericardium is that thin membrane which is ranging from 1 to 2 millimeters membrane protecting the heart. Okay? Now usually we have 10 to 50 mils of pericardial effusion for lubrication and purposes, and for the heart to create frictionless environment within the sac. Next page, please. So, what is a cardiac tamponade? So, some of the patient you heard and you understand that some of the patient with a large pericardial effusion been relatively well. Now, the cardiac tamponade is acute accumulations of pericardial fluid, and the reason I say a buildup of fluid can be various forms. It could be serous, which is transudate, exudate, blood, pus, or anything. Now remember today's setting. Now I want to give you a little bit basic or mechanical issue about cardiac tamponade, because today we're talking about ECMO. But you have to understand the disease process before you apply your mind to ECMO, okay? So, cardiac tamponade is acute and rapid accumulation of pericardial fluid that causing the malfunction of the heart. Now, in this scenario, some of our population, we have seen TB pericarditis and pericardial effusion. And recently, we're seeing one. We actually evacuated almost about 700 to 800 of serious fluid from the pericardium. And the patient is completely asymptomatic. Are you short of breath? No. Are you walking around? Yeah, now and then feels a bit weak, but I'm fine. I'm doing my work. And that's the issue with the time frame of cardiac tamponade. Next. So there's, once again, there's a whole list of the reason, of course, cardiac tamponade. But let's coming back. So this is just for you to read and understand. And the whole idea of reading them and understanding them is that when events happen, you have something in your drawer and say, okay, let me quickly think through this list. With patient's history, which one will fit in? Right? Next page. So now, how does it work? Now, obviously, I'm trying to illustrate. So our pericardium is a protective measure. So you know there is a little bit of pericardial effusion around it when you perform an echocardiogram. And what happens is that with a rapid accumulation of fluid around the sac, causing compression to the chamber. So if for the heart to work well, it's a pump action for the muscle for the ventricle to fill, and for it to contract to pump out the necessary volume. But in this scenario, when there is a constraint, now remember the very first slide, the anatomy, you do not have a lot of space. Now, if you have a slow accumulation of fluid, a pericardial effusion like TB or some disease, what happens is that you have fluid accumulated like 2 to 3 mils over a duration of a month or so. So slowly your body accustomed to it. But in a rapid accumulation, your heart is not used to decrease the volume, which it will manifest systemically. And this is the next page, please. So now this is the picture. Your heart is screaming. Say, you know what? So basically you can see that the signs are you begin to have distended neck vein. So basically your heart is full with fluid. Your heart cannot perform its function. Now, atrium's function is act as a reservoir. So on the right hand side where the desaturated, deoxygenated blood return to RA, and before we go into the pump, which is RV pumping towards the lung. Now, if you have fluid constrained process, the heart cannot fill anymore. You will see that the patient's neck vein is distended. Now, at the same time, remember, you don't have a blood coming in and going out. So you're going to have hypotension. So these are the issues. So if you have any, if you remember this picture, you'll realize, and this happened rapidly. Patient could be speaking to you, 2 minutes, I'm okay, but short of breath. Next minute, you will see that it accumulated quite fast, and decompensation, it happens in a split second. Next page, please. So this is a basic, so a lot of time like this, you can see the sternal wire. So this is a post-operative pericardial effusion, right? So X-ray, investigations, you can do an X-ray, globular heart. It tells you they are pericardial effusion. In keeping with patient's clinical presentation. Next. Next, it's a quick ultrasound. Patient with a rapid deterioration, minor intervention quickly. So basically, but if you've been through a cardiac center in St. Anne's or Midlands, or as well as in Mediclinic, you'll realize we always put a drain post-surgery when we close the chest. That is to prevent cardiac tamponade. So therefore, but if some of the patient post-bypass in which have LV dysfunction, cannot come off the bypass machine, we put them on VA ECMO. Sometimes we don't close chest at all. So we use a central cannulation and then maybe peripheral venous return, but their chest, we didn't close their chest and we just seal it up and we return them to ICU. So the chances are not that common. But if you have read the Alfred guidelines, it tells you patient post-cardiac surgery. Now, in that scenario, what do? You turn the rave down, you call the team. That's why prompt response with the team is absolutely crucial, because you need a surgeon. What do? You either do a Zephyr pericardial window, you go in there. First, you can attempt it. This is the first step, which is what we call pericardiocentesis, right? So in that scenario, we like the patient to be at a 45-degree angle. The reason being is that fluid settle with the gravity. Now, if patient is lying flat, sometimes if you got large enough cardiac tamponade, no matter how you put a needle, you will get the fluid out. But time to time, with the 45-degree, the fluid settle, you will see the fluid settle there. If the patient is ventilated, all you do is that you took a 16 or 18 gauge needle pointed towards the nipple or 45-degree angle. Why? Because the pericardial sac is sitting right here. You put a needle in under ultrasound guidance. As you go in, as you inch, obviously this is done through Saulinger technique, but if you go through a centimeter by centimeter with aspiration, as soon as you hit the fluid, most time it's serosanguinous, sometimes could be blood. So as soon as you hit that, you breach that pericardium, you will see the large aspirate, and that's the time we can put in a drain. Now a drain could be a pigtail catheter, which is Aeroset, or we can put in a CVP, just to allow us to aspirate quickly to restore the cardiac function. Okay? Now, whereas if patient had a median stenotomy already, we'll quickly reopen that, evacuate the clot, and then allow the ECMO to proceed. Now, the other way where we did a pericardial window is subxiphoid. So we make a little cut in theater, or where emergency is, we lift up the xiphoid process, we can see the pericardium there, we cut a little window, and we'll put a sucker through. And that, time to time, will solve the problem. And that's the end of my talk. Thank you very much for attending.